the ICD leads do fail, and they are associated with vascular problems, and they do get infected. And when they get infected, the mortality and morbidity associated with extraction is actually not negligible at all. So the early complications with ICD implants, the transvenous, can be up to over 10%, 12% the first year. And when you have to open a pocket because of an repositioning or dislodgement, your risk for infection will actually go 10 times more. And finally, if you extracted a system, transvenous system, because of an infection, your mortality at 1 year is 12% for only pocket infection. And if you have an endovascular infection, your mortality is up to more than 30% after 1 year. This is dramatic for me. So now that would lead us to why we think of a subcutaneous system. It's a completely subcutaneous, so you don't have intravascular elements. The device sits actually at the lateral part, at the mid-axillary, straddling the mid-axillary line at the level of the heart, and then the lead actually tunneled to the substernal notch and then up the lateral, left sternal edge of the up. So it eliminates the complications related to transvenous systems. There's also a limited amount of fluoro. You actually can do the without fluoro just to check your lead. You can step outside the lab and do that. And because of the way it senses, it's kind of far field sensing, it's better in discriminating supraventricular from ventricular arrhythmias. And it gives you actually access to some patients who cannot have this system because of vascular problem. A couple of things about sensing. The lead actually has 2 electrodes for sensing, proximal and distal, and the coil is in between. So you have 3 vectors of sensing between the device and the proximal electrode, device, and distal electrode, and between the 2 electrodes. So you see what look like an ECG signal. So your discrimination is very good for VT versus SVT, but that also can put you at risk of seeing something else like the T waves. Now, by the way, we used to do this vector testing by ECG manually. Now the device does that for you and tell you whether it passes or fail, and you have to have at least 1 vector passing so you can implant the device. The IDE trial and the START trial that led to the CE mark of the device was starting in 2009, 2010, and gives us good result that sensitivity for detection of VT using this device was very good. The specificity was excellent, differentiating SVT from VT. And the shock efficacy was very good, so up to 95% with the first 65 joules. Remember, this device is capable of giving 80 joules. The mean time for charge was 19.2 seconds, which is long, but probably that's not bad given the fact that many arrhythmias do terminate spontaneously, we know that. What we want is real life and data of what we see normally in practice, and that's actually the function of the registries. This is the EFFORTLESS registry. It's mostly European registry with New Zealand that is ongoing, and they presented their 1 year and then 3-year follow-up. And now they were waiting for probably the 5-year follow-up in 1.5 years or so. It recruited over 1,000 patients in several sites in Europe. And the primary endpoints was complication caused by the S-ICD at 1 month and 1 year, and the inappropriate shocks due to supraventricular arrhythmias after 1 year. So I have the 3-year follow-up, which was published or presented in the HRS 2016 for almost 500 patients. The characteristics of the patients, they tend to be actually relatively young. The ejection fraction is not bad, 43%, and 1/3 of them had the device implanted for secondary prevention, 1/3 for primary with low EF, and the rest are primary with good EF, and those are the channelopathies and the hypertrophs. For the primary endpoint, for the freedom of complication caused by the function of the S-ICD, were excellent. At 90 days, at 30 days, 99.7 freedom of complications, and 98 at 1 year. How about inappropriate shocks for SVT, the atrial fibrillation supraventricular arrhythmias? If you look at that, it was very good, 1.5% at 1 year and 2.3% at 3 years. But this is for inappropriate shocks due to supraventricular arrhythmias. If you take total amount of inappropriate shocks, actually at 3 years was 11.7, and that was caused by inappropriate shocks due to mostly T-wave oversensing. Let me go back here. And if you let me show you something else here. And if you look at the results of the, let's see if I get this one right. Yes. The other study that is going on, which is also a prospective study, but in the US, post-approval, that also have over 1,600 patients. They tend now to be sicker. They have low ejection fraction, 32%. They have more comorbidities, 13% have dialysis. And 2/3 of them actually still done under general anesthesia with 2 incisions in 50%. They are showing the same results also. The conversion rate for induced VT is excellent. The 30-day complication-free actually is excellent, 96%. And the predictors of complications were diabetes, young age, and higher body mass. Now, comparing the effortless trial, which actually, I don't know why that slide didn't show up, but the effortless trial showed that there was higher risk for infection in those patients, around 10 to 11%. That was early on during the learning curve of doing those devices. The infection rate actually became less as we learned how to prepare our patients and improve technique. So the results of the post-approval study in the US showed that the infection rate is low and probably similar to what we see with the transvenous ICD. That leads me to the UNTOUCHED trial, which was presented in HRS last year and was just published in the Heart Rhythm Journal in November this year. And this is the first trial that prospectively looked at implantation of the S-ICD system and primary indication in patients who have low ejection fraction. So it took patients for primary prevention, less than 35% ischemic or non-ischemic, who passed the ECG screening for at least one vector and had no indication for pacing. And it was a prospective, non-randomized. Looked at safety endpoint, which is complication-free rate at 30 days, and efficacy of conversion of induced arrhythmia. You can see that the patient characteristics here, they are again becoming more sicker, like what we normally do for prime prevention. All of them should have low ejection fraction by design, but they have more comorbidities. And if you look at the conversion rate, the success rate with the UNTOUCHED trial was excellent and similar to the IDE trial and the effortless and the PS registries. If you look at the complication-free events, where actually it's 95% complication-free after 1 month, which is again very good because this is all complications, so the risk of infection here again was low. So there's 2 or 3 things we need to discuss when we talk about the S-ICD system. Number one, the inappropriate shocks. In the early trials with the effortless registry, we saw that there is an increased number of inappropriate shocks, up to 9% in 1 year, and that's mainly due to T-wave oversensing. Yes, it differentiated good between SVT and VT. 2 things that happened with the S-ICD system that reduced this rate, which was going to 2-zone programming, where the VT zone can be programmed to discriminate between SVT and VT. And the other thing which was very important is actually applying a high-pass filter in the 2nd generation of this system. And when they took a model and applied the high-pass filter on events of the patient with the effort trial, for effortless trial, for example, there was a 40% reduction in T-wave oversensing. So that significantly reduced with this high-pass filter. The other thing is pacing. We know that this device does not pace. It only paces for 30 seconds after a shock. So if you have a patient who has an indication for pacing, whether it's Brady, anti-tachycardia pacing, or CRT, you should not implant the device. The question is how often you need pacing for those patients. And if you look at prior transvenous trials, when you have a patient coming for an ICD implant, only small percentage, probably less than 7%, are candidate for pacing at that time. And if you look at the MADE 2 and the SCULT-HEF trial, the people who actually required pacing down the line after having the device, actually less than 2% per year. So in general, ICD patients who have no prior indication for pacing tend not to need it in a big or significant way. And a longer PR interval actually does predict who will need pacing down the line. The anti-tachycardia pacing is like fashion. Sometimes it's in, sometimes out. When you're using it and successful, we say great things about ATP. If you look at one of the biggest trials for the primary prevention, the SCULT-HEF trial, if you look at the percentage over 5-year follow-up of this trial, this is a primary prevention trial in heart failure patient. How many patients required or had multiple episodes of monomorphic VT that could be terminated with ATP? Actually, over a 7-year period, there was only 7% over a 5-year period. The other thing, if you look at the MADE-3 trial with this new programming or high rate or longer delay, and with this programming, you reduced ATP, but the percentage of appropriate shocks delivered were not big difference from the percentage of appropriate shock given by the S-ICD. So the shocks did not change. You reduce a lot of ATP, probably both arrhythmia would have terminated by themselves. So the ATP, yes, if you have somebody with non-VT monomorphic, you should put a device that paces, otherwise probably not a lot of people will need it. What about if you put the S-ICD and turn out to have need for pacing down the line? This is very rare. Need for pacing, actually, with the EFFORTLESS registry after 3 years, less than 0.5% for indication for ATP, less than 0.4% for indication of Brady. So it's very, very small percentage who gets an ICD, S-ICD that will need actually revision or explantation of the device. Finally, for infection, the high rate of infection that occurred with this device early on turned out not to be true down the line. And this is a meta-analysis from 5 case report studies where it showed that the infection is similar between S-ICD and the transvenous ones. And the most important thing is that when you explant transvenous system and put S-ICD, there is no increased risk for infection after the S-ICD. We are refining the procedure over time, so most of us, they do 2-incision technique rather than 3. I think intramuscular implant is very important. It reduces the risk of erosion, of infection, better cosmetic, and better defibrillation threshold. We do it under general anesthesia most of the time, which makes the procedure longer, and you have to be dependent on the anesthesiology team. We have done now serratus block in our patients, and actually they do very well. How about DFTs? Can we do without them? I have to admit I have done around 100 S-ICD patients. After the first 20, I stopped doing DFTs, although it's recommended to do it. There's a Praetorian DFT trial that's trying to examine whether we can omit DFT testing by using the Praetorian score, which is mainly looking at X-ray and make sure that your device is posterior and your device and lead are deep, not a lot of fat underneath, basically what it is. I will skip this for time purposes. I will leave you here with the recommendation for the S-ICD implantation. This is the 2017 recommendations. It's a class 1 indication. If you have somebody who is indicated for an ICD but has a vascular problem or high risk for infection and who does not require pacing. Class 2A indication for somebody who had an indication for ICD implantation and no need for pacing, regarding whether it's a higher risk patient for infection or not. And you should not put this device in somebody who actually requires pacing. Just a couple of points, and I'll stop here for actually technical points. You mark your positions of the device and the lead. And your device should be basically straddling the mid-axillary line at the level of the heart. But do not make your incision over the device. Make it a little bit higher and parallel to the muscle fibers. And then you will find better that space between the serratus muscle and the latissimus. And that's a vascular place that you can dig in and make your pocket there. And then you close the muscle outside, and your pocket is actually, your device is hidden. So the risk of infection and erosion is very low. And I'll actually just conclude here because of time. So I think we have data on the short and medium term follow-up that the S-ICD is safe and effective. It eliminates complications due to vascular issues regarding the transvenous leads. I think the candidates are people who actually high risk for infection, no vascular access, young patients with inherited arrhythmias. In my opinion, down the line, I think we'll see more and more patients who are regular candidates for ICD, whether it's primary or secondary, but who do not require pacing. I think the development of this technology with more programming and more capabilities will probably increase the use of this system. And thank you very much.